Your nebulizer treatments can nebulize a steroid, transdermal. You can get the fentanyl patches, intramuscular, IM shots. Intravenous is just that subcutaneous. We have sub-Q sets, and we do use those at home. We'll put it on as long as the amount of medication they need. Sometimes we'll put a pump on if the amount of medication is more than what the caregiver can give safely, because if there's only one caregiver and they're doing this 24/7, they're not going to be able to do that every 1-2 hours, which you guys can do in a nursing home. And so we do use those with a pump sometimes. And we do pumps for the patient who can't get the pain control, or the amount of medicine they need is so high that they need a pump. And then intrathecal. Occasionally, we have sent them in to have an intrathecal injection done in the emergency room or someplace where they go in. That's when they're pretty young yet and ambulatory and able to get out. A little extra on the subcutaneous sets they may use for insulin pumps, pain pumps, occasional injections. The one thing on there, it maxes out at 3 meals. So you cannot give more than 3 meals an hour in a sub-Q set, okay? The site change for us is usually every 5 to 7 days, or if it, sometimes before, if their body's not absorbing it, it's going to be leaking out and turn red. And if you see that, it needs to be changed. And we always prime the set with medication, and we never flush it with saline. Because otherwise you're going to flush it, the next dose they're going to get is going to be pure saline. So we never flush them with saline, because then we already maxed out 3 meals in the site. Bucomorphine is a high concentrated amount, it's 20 milligrams per meal. It frightens me when I get a phone call and I have a death and I go to the death and to the home, and guess what's missing? The vial of 20 milligrams of the high concentrated morphine. That is a federal offense. I have to call the law enforcement and they will do an investigation. The family is told before I leave, a law enforcement officer will be here and they will come and get your statement what happened to this medication, because it's our responsibility to dispose of it at the time of death. It absorbs in the cheek of the mouth, and the doses can be split, because we try not to do more than meals, so you can split it here and kind of alternate the cheeks back and forth while they are absorbing, and so that if you're given a lot, you don't need to do all on one side. If they swallow it, it's okay, it's still going to work. And when not to use it is when, like I say, more than 1 cc per dosing, the caregivers need to dose very frequently and not able to rest. That's when we probably end up switching to some other type of form for them. And then our nursing process is basically we're planning and implementing our pain control, our pain options, our patient options and control. It's a team approach. Everybody in hospice is a team approach. Patient education, and then at the end we evaluate, has the outcome or our goal been met? Has the patient's goal been met? That is the #1 thing. When we do our admit, we try to say, what is your goal? What would you like to do this time you have left of your life? And sometimes people may say, I want to go on one more fishing trip. I want to just be home with my grandkids. And so they, you know, and some people say, I don't know yet. No. And they may not have a goal. Most family members, #1 thing, keep them home, keep them comfortable. And then our last slide is here's for references. There's different ones there that you can go on there for further information and stuff too. And that's the end of our presentation. Does anybody have questions?
Comment?
Oh, we're right down there.
Right on.
Good thing I talked fast again.
Thank you.